Okay, I'd like to welcome everyone today to the COVID-19 Diagnostic Testing and Clinical Management session sponsored by the MassCPR. The goal of this session is to reflect on where we are now in COVID-19 testing and management and where we are going. My name is Rajesh Gandhi. I'm the co-director of the Clinical Management and Outcomes Working Group of the MassCPR. I'm also an infectious disease physician at Mass General. This will be co-moderated by Dr. Karen Jacobson, the co-director of the Clinical Management and Outcomes Working Group at Boston Medical Center, and Dr. David Walt, the co-director of the Diagnostics Working Group in the MassCPR at Brigham Women's Hospital. We thought we would set the stage very briefly by just talking and reflecting on where we were about a year ago in the area of these topics. And we'll think back about a year ago to our hospitals filling up with patients with COVID-19. Reports from around the world touting the potential use of things like hydroxychloroquine and azithromycin. The uncertainties that we had about whether steroids did or didn't benefit patients, whether turning a person on their stomach would prevent the need for mechanical ventilation, and the very beginnings of clinical trials to try to understand how to treat COVID-19. I reflect back on the fact that in April, when a number of guidelines committees met, each of the institutions around the country were developing their own guidelines, but 2 guidelines committees formed rapidly in April. But their first guidelines were things like this. The Infectious Disease Society of America said that there were essentially no recommendations for COVID-19 treatment for now, and knowledge gaps were cited. And the National Institutes of Health also formed a guidelines committee and commented that there were essentially insufficient data for or against any of the therapies that were being discussed. So I'll just conclude this stage setting by reflecting on COVID-19 really can draw lessons from HIV and other pandemics. The fact that we need to deploy interventions has to be tempered by the importance of finding out if a treatment does or does not work. And in fact, it's been said that randomized trials not only can be done during a pandemic, but absolutely must be done during pandemic, since by definition, during a pandemic, one doesn't know what does and doesn't work. And finally, clinical management very much is an iterative process, as it was with HIV, where one makes one advance and then builds upon it. And so with that, I'm going to turn the slides over to Dr. Karen Jacobson. Over to you, Karen.
Thank you, Raj. So, and similarly, when we think back on clinical outcomes and where we were in March 2020, as we watched the pandemic hit initially in China and then moving into Europe, and I think most aghast looking at Italy, there was a sense of how would COVID-19 play out in terms of clinical outcomes. How similar was this to other viral infections such as influenza, and how different were we looking at the time the WHO was putting out these remarks in March of 2020? And then those of us here in Boston and other parts of the United States looked across, and as we said, very much had fears of how high the death rates would be and would our hospitals be able to hold. Next. And so again, these initial questions were, what was the case fatality rate? Who was most at risk for poor outcomes and who needed to be targeted both for support and for most interventions? How long would hospitalizations last? Because that would impact on capacity. And would we see any sequelae from this after people recovered from the acute infection? Next slide. And so what we began to do is organize our data and start to say that realize what were the importance of having both observational as well as prospective cohorts that we could start to tap into to see what patterns we might see. Next. And very quickly over the next few months, it became appreciated that there were high risk for disease in certain groups. So age clearly became a very significant risk factor. And as we see now a year later, who's being targeted for vaccines early in the United States and hopefully soon globally are those of the older age risk groups. that there seemed to be some gender difference, that men seem to have worse outcomes than women. That once it hit the United States and we have the wonderful diversity that we have in this country, we came to appreciate that certain race and ethnic minority populations were having a difference in both burden of disease as well as outcomes, but that it was a real pivot to what we've known in many other parts of field of medical health, that social determinants of health were really what was driving a lot of this differentiation, and these needed to be urgently addressed. It was easily recognized that case fatalities were worse than influenza, particularly given that influenza had vaccines, and that we've come to appreciate, we see in this Nature Medicine recent review, and will be reviewed again later today, that post-treatment sequelae is something we will likely be living with now for decades after this acute infection. But most of all, we had the takeaway that we needed diverse, inclusive cohorts, both for clinical trials as well as we said, outcomes research, to be able to track disease efficiently as it hit our populations and be able to pivot and make these levels of support.
Thank you, Karen. As soon as the virus was detected in the US, we all recall that there was an immediate shortage of diagnostic testing capacity. There were supply shortages with assay reagents, nasal swabs, and even with sample tubes. We also recall that there was rapid introduction of tests, and FDA approved with EUA approval many tests that were followed by recalls because of performance issues. On a more positive note, the public learned about science. They learned about PCR, antibody and antigen tests, false positives and false negatives, but we still haven't gotten to the point where we have sufficient testing capacity. Next slide. So the lessons that I think were takeaway from this early part of the pandemic were that scale matters. There were over 2,000 companies that were working on COVID tests globally, but most of them did not have the experience or the capacity to scale at the levels required. Only the big diagnostics companies had the manufacturing capacity to really supply the testing demand. And there was obviously a huge waste of investment into many small companies that could have been better spent on scaling for a smaller number of more mature technologies. We also learned that independent validation is essential. We can't leave it to the companies producing these assays to validate their own products. In some cases, they tested fewer than 30 samples, and in that sample cohort, over half of them were positives, which was well above the single-digit % prevalence in the real population and led to lots of missteps. And then we learned that all testing strategies are needed. As the tests roll out, we need to invest in and implement technologies and tests that address all three use cases, including central testing, point of care testing, and at-home testing, so that the sort of delays that occurred with this round don't occur in the future. So to just launch ourselves into the symposium now, I'd like to introduce Sara Suliman from Brigham and Women's Hospital, who will give the first diagnostics talk. Sara?
Thank you so much, David, for the introduction. It's a pleasure to be here today. So I'm an instructor in medicine at the Brigham and Women's Hospital and an immunologist by training. And I've been involved with the diagnostics pillar of the COVID Innovation Center since the beginning of the pandemic. So first, to introduce the need for diagnostics for COVID-19. As you can see on the left, these are the different analytes that are expressed by COVID-19 patients and the kinetics of their expression over time. So you can see at the beginning, we see a high proportion of positive tests when we detect these by PCR, which detects the viral RNA. And you can see that antigen tests are really good at detecting viral antigens within a week from diagnosis, whereas antibodies like IgG and IgM take about 10 days to be detectable by these patients. So in response to these kinetics, different types of diagnostics have been developed. So there are molecular tests which detect the nucleic acid from the virus, antigen tests which detect the viral proteins, and serological tests which detect these antibodies. So just to explain these technologies in a bit more detail, molecular tests generally rely on PCR or polymerase chain reactions. So as you can see in this graph, we can amplify the genetic material of the virus, and the longer it takes to amplify these genetic materials, it corresponds to a lower amount of virus. So a higher CT value means that you have a lower viral load, whereas a lower cycle threshold value or CT value means that you have a higher amount of the virus. And serological assays come in different flavors. What I'm showing here is a lateral flow assay, which looks like a pregnancy test. And you can see a control band, which indicates that this is a valid test. And then a line would appear at the test line here, which indicates that you have a positive IgG or IgM antibody. And then rapid antigen tests come in different flavors as well. What I'm showing here is also a lateral flow assay that looks like the antibody test. And these are ideal for community testing and implementation in resource limited settings because the turnaround time is very low. So at the beginning of the pandemic, reflecting on we were a year ago, the market was flooded with different types of tests, as David mentioned. Of course, this resulted in a lot of panic since there was a lot of flawed tests that flooded the market. And as a result, the FDA has actually recalled a lot of these tests that were not properly evaluated and called for standardized evaluation of these technologies. So in response to what was happening at the beginning in diagnostics, the Mass General and Brigham hospitals formed a COVID Innovation Center. And as part of the COVID Innovation Center, we had a Diagnostics Accelerator lab, which is located in Charlestown in the Navy Yard. We were initially staffed by volunteers from both hospitals. And now we have staff, 4 technicians in the lab who perform evaluations of new technologies for COVID diagnostics. And so what does evaluation entail? This is a 2x2 table that we use to guide our evaluation protocols. So as you can see on the left, we see the diagnosis of the patient using a gold standard as either positive or negative. And then we evaluate the new test in hand. It could be a molecular test, an antibody test, or an antigen test. So then we triage the performance of the test to identify how many of these were true positives. So we calculate the sensitivity, which is the proportion of individuals who were positive that were detected accurately by the new test. And then we also calculate the specificity, which is how many of the negatives or the uninfected controls were detected accurately. And of course, we can also detect the positive predictive value. So out of the tests that were positive, how many actually corresponded to cases, and similarly for the negative predictive value. We also calculate the interoperator reproducibility and the limit of detection, particularly for quantitative assays. So we also extended our activities outside the Diagnostics Accelerator to evaluate tests in real life settings. So I partnered with Dr. Louise Ivers at the Mass General Hospital and the Holyoke Board of Health. So this is the Stop the Spread testing site in Holyoke, Massachusetts. And people come in to get tested. So we planned a study where we swabbed individuals for both the regular PCR test, which was performed at the Broad, and a rapid antigen test. So you can see here, 2 examples where we have both are valid tests. So they have a line at the control band, but we have a negative example on the left and a positive example on the right. So this was obviously a huge team effort, and I particularly want to thank members of the Holyoke Board of Health who made this work possible. And then we also extended our activities by forming a global consortium of different partners. So now we evaluate rapid tests in multiple countries. Bangladesh, Kenya, Malawi, and Botswana. And this is an example from the field evaluation that was conducted in Nairobi. So you can see the rapid tests that are being evaluated and compared to the gold standard PCR method. So a year later, what we learned is the value of decentralized testing, which was made possible by the availability of these rapid tests, but they needed to have standard protocols for evaluation before they can be deployed for mass surveillance. So in summary, standard evaluations of COVID-19 diagnostics are very critical, and these should be tailored to the use case, like whether you want to implement them in a point of care setting or for home use or for other implementation use cases. And the community of scientists that formed at the beginning of the pandemic really accelerated the progress, and we were able to evaluate many tests very quickly. And this can serve actually as a model for infectious disease or emergency preparedness, both locally and globally. And with that, I will pass it over to my colleague, Sanjat Kanjilal from the Brigham and Women's Hospital.
Thank you very much, Sarah. And just a reminder for participants, if you have any questions, please put them in the Q&A section in the Zoom, and then we will get to those at the end. So I first want to thank David, Raj, and Karen for the opportunity to speak at the MassCPR Symposium. It's really an honor to be in front of such an amazing group of individuals. And so, testing for active infection with SARS-CoV-2 really falls under two paradigms. Number one, strategy one looks for symptomatic people or those with exposure and high pretest probability for infection. And the use of testing in those cases determine the treatment strategies that Dr. Kim will talk about in the next talk, as well as prognostication. And so the optimal test characteristics in strategy one are those with high analytic sensitivity, because we're trying to understand whether we can catch people early in infection with low levels of virus, as well as a rapid turnaround. Strategy number two is very different in that it looks at a much larger population of asymptomatic individuals who are at low pretest probability for infection. And the use here is to actually assess whether they are silently transmitting the virus to other susceptible hosts. And so the optimal test characteristics in strategy two are to maximize specificity, because a positive has implications for quarantine and a false positive could have some dire implications for someone's economic well-being, as well as scalability. And so to meet these new testing paradigms, the clinical lab medicine operations and infection control communities really had some major accomplishments over the last year, and I'm just highlighting a few of those here. First and foremost was the increase in testing capacity, which was sort of predicated on shifting to alternative specimen types, such as nasal swabs and saliva, pooling in certain circumstances to increase efficiency, as well as a relaxation of their regulatory burden from the FDA. There was sort of an appreciation from the community that not all positive tests should be treated the same. And so we were able to use semi-quantitative markers of viral burden that we're drawing off our instruments to make better use of limited physical space for isolation, as well as reduce the rates of unnecessary quarantine in people who may just have residual amounts of virus remaining. And then with regards to asymptomatic transmission, both modeling studies and real world data quickly showed that serial testing paradigms are able to overcome that limited sensitivity respiratory viral testing, but required a great deal of infrastructure investment for that. And above all, as Dr. Walt was saying earlier on, there was, over the course of the past year, a recognition of the important role that clinical laboratories play, both in control of the pandemic, but also just in general diagnostic testing for the general public overall. So that being said, there were a lot of stumbles in the realm of diagnostics for COVID-19, which should be familiar to all. I'm not going to go into great detail about them, but sort of the high-level takeaways that I want to convey are that the perfect test can be the enemy of a good test and can actually harm people during a rapidly evolving global pandemic. And similarly, a one-size-fits-all approach may not work when testing serves multiple paradigms, as I showed in the first slide. We had an over-reliance on high-throughput centralized laboratories, which created really severe bottlenecks in supply chains and major headaches downstream. And then there's a complete lack of infrastructure to share test results across health systems, which constrains our ability to make rational decisions for public health at the systems level. So despite all our work, I would argue that we still lack a testing paradigm that meets these 6 criteria that I outlined here. One that is accurate, rapid, frequent, with widespread coverage of the population, non-invasive or comfortable for our patients, and inexpensive. And this is a major problem because much of this falls on our most vulnerable populations. And so this is just a plot of data in the Boston area showing the gap in testing, which is defined as the number of people who need to be tested relative to the number of people who have infection in a given region over time. And you can see that the red bar here indicates those who are at the highest socioeconomic vulnerability, and that not only has this gap persisted, but it's actually worsened over time. And so to quote my colleague, Dr. Dryden Peterson, despite programs to promote equity and enhance epidemic control across vulnerable communities, resources in Massachusetts have been disproportionately allocated to more affluent communities. And speaking of vaccine, why does testing still matter with the vaccine era? There's a couple of reasons for that. Number one, it will take many months for the US population to get vaccinated overall. And then similarly to testing, there's this gap between those who are vaccinated and those who are at highest risk for both infection as well as complications, and that gap may be worsening. Most of the world's population will remain vulnerable throughout 2022 and possibly 2023. As we know, society, when it reopens, rates of infection are expected to go up among all populations. And then testing is really critical, tracking the spread of variants, as well as assessing the vaccine efficacy against variants and in populations that may have been underrepresented in clinical trials. Now, it's not all doom and gloom out there. I think there's a lot of really exciting work going on within the CPR as well as outside of it. And I just want to highlight a few examples here. The first concept is that of next generation surveillance, and not surveillance in the sense of the KGB or the CIA, but rather surveillance in the public health sense. And the concept is to build a predictive model that is able to take multimodal inputs from environmental wastewater surveillance, point of care diagnostics, and next generation syndromic surveillance through wearables or sensors, and through common data models, build predictive models that are able to identify outbreaks when they occur and stop their spread before they get out of control. Another example are rapid point of care assays. This is an example from Dr. Sabetti's lab, who's a co-chair of the Diagnostics Committee for the MassCPR. And this is an assay that meets many of the criteria that I outlined earlier for being the ideal testing paradigm, in that it's rapid, it's point of care, it's sensitive, it's specific, and it provides a readout to public health authorities via a smartphone app. Another example is work from Dr. Walt's group, who's also the other co-chair of the Diagnostics Committee. And this is a technology that may revolutionize the way we actually assess for immune protection against viral pathogens. And not only does it detect the presence of antibodies, but also whether they function to neutralize the virus. And the key innovation here is that it's able to do it rapidly and at very high throughput. So ultimately, until our epidemiologists have told us that we're able to have parameters on the number of people who are expected to be hospitalized or die from COVID-19 every year, our testing paradigms must include asymptomatic people in populations at highest vulnerability. And so in order for that to be successful, we must make equity a core principle of our testing strategies, and there needs to be funding to establish collaborations between public health agencies, diagnostics companies, and hospital academic labs, and of course, consortium like the MassCPR. So with that, I will turn it over to our next speaker, Dr. Arthur Kim, and he will be talking about COVID-19 management strategies.
Great. Thank you, Sanjat. While I'm getting this up, are you seeing the proper view? So thanks for the invitation to speak on the treatment of COVID-19. By way of disclosure, only remdesivir is approved by the FDA, and all of the treatments that I'll talk about are off-label or used under an emergency use authorization. So briefly, I'd like to give an overview on the story of how we've repurposed or deployed therapies for COVID-19 over the past year to arrive at the current paradigm. The rewinding to a year ago, we can recall how it started in Boston at the Biogen Super Spreader event, just a short walk from where I sit at MGH. And as of early March 2020, we faced a tsunami of patients without effective treatments, without clinical trials to offer, and with intense pressure to act. And a dizzying array of repurposed treatments were proposed, ranging from A to Z, from azithromycin to zinc. And why were there, and there continues to be, so many potential treatments? Well, the reason is that one could theoretically intervene along multiple steps involved in the pathogenesis of SARS-CoV-2. First, one could directly target the virus itself, its receptors, ACE2 or TMPRSS2, or downstream steps of the viral life cycle. And next, it became clear, as Karen alluded to, that some people suffered from severe viral infection more than others. And this schematic links that severe illness to a delayed or blunted innate immune response. And so theoretically, one can optimize immunity with therapies simple as vitamins or as direct as say, type 1 interferons, with the goal of shifting to a milder disease course and keeping people out of the hospital. Now, once in the hospital, we quickly learned that the sickest patients exhibited signs of hyperinflammation and linked hypercoagulability. However, we didn't know at the time whether anticoagulation or dampening the immune response, especially amidst an active viral infection, would be helpful or even harmful. And so between targeting the virus or the host, virtually any drug could be taken off the shelf, an immense array of approaches to modulate your favorite pathway or your favorite cytokine. So how did we confront this deluge of possibilities? Since March of last year, I've led a task force within our ID division to provide guidance that we call CHANT, or COVID-19 Here and Now Treatment. And through daily meetings at the time, very interdisciplinary across divisions, together, we learned firsthand about the disease while distilling the deluge of literature and reports from all over the world, and applied our collective thinking in real-time fashion. And remarkably, in parallel at MGH and across the world in various hospitals, to respond to the need for randomized trial data, teams launched, in this case, within days, an NIH-sponsored trial called ACT-1, which tested remdesivir, an antiviral drug originally used for Ebola virus. And remarkably, just several weeks later, we had information that allowed the FDA to authorize its emergency use, and we began implementation within days after that. By April, we had already withdrawn an early mistake of using off-label hydroxychloroquine to prepare for yet another network trial, which along with many others proved that hydroxychloroquine did not work. During that same time frame, we also launched Back-Bay, a randomized trial of tocilizumab, an IL-6 receptor blocker. And through all of this, we learned so many lessons, but among them is to first avoid a temptation to prematurely deploy therapies. Just because a drug sounds great, hydroxychloroquine had both antiviral and these immunomodulatory properties, but it still doesn't mean that it'll work. Rather, we should promote clinical trials and from those results precisely deploy therapies, which we did through this CHANT mechanism, which by the way continues to meet. We're having our 150th meeting this afternoon. By mid-June came a bombshell announcement that dexamethasone actually had a mortality benefit. And this was shown here on the left in the survival curve, where dexamethasone is associated with lower mortality in the recovery trial. This trial is run by the National Health Service in the UK, and it benefited immensely from its centralized system. It was pragmatic in its implementation, and it was adaptive. And this protocol could add or subtract therapies. And through this effort, they've remarkably enrolled about 13% of the overall UK hospitalized population. And through these sheer numbers, recovery has told us the most about what therapies not to use and what therapies may save lives. And recovery gave us this proof of this life-saving therapy. Now, we have a mounting body of evidence today that for outpatients, we can use a combination anti-spike monoclonal antibodies to prevent hospitalization of high-risk outpatients. And this is really the main and only outpatient therapy we are deploying. It's approved under the emergency use authorizations. Now, and we alluded to remdesivir. This antiviral has a so-called sweet spot of efficacy where the benefit is most evident, namely in hospitalized patients on low flow oxygen. Now, neither of these antiviral approaches, although they sound attractive to treat a viral infection with antivirals, they were not proven beneficial in these randomized trials in the sickest patients. And so this confirms that it's best to deploy these antiviral strategies during the earlier phases of COVID-19, where the virus is the main driver. So this slide summarizes how it is going today. We are currently in a much better place than we were in March 2020. So timing is everything, as just explained about the antiviral approaches. Dexamethasone benefits the sicker patients, but may cause harm if deployed during an earlier stage by enhancing viral replication. Now, tocilizumab has a long saga that we can't review in detail in this talk, but it is being currently deployed in this so-called sweet spot if patients have progressive oxygen requirement and hyperinflammation while already on dexamethasone. And while we don't have the details, we're anxiously awaiting them. We're awaiting some promising data for anticoagulation. But again, this fits the theme. This may be beneficial for one particular stage of disease progression, but not all stages, as it was, the trials were stopped for futility in patients on mechanical ventilation. So looking forward, we face several remaining challenges in the treatment of COVID-19. The imminent challenge of viral evolution that threatens the use of these monoclonal antibodies, a critical need for a safe and effective orally administered outpatient agent, as intravenous ones are hard to deploy on a mass basis. And we're currently facing daily challenges in managing immunocompromised patients for a variety of reasons. And you'll hear about the next two issues in the following talks. So in sum, the pathogenesis of this virus reveals a vast array of potential therapies, and we've learned that it's critical to target the specific stage of illness, antivirals early and immunomodulation late. And in particular, we've learned the value of adaptive network trials to sort through this potential chaos, and investment in these trial networks will be critical for future pandemics. Thanks for your attention. I'd like to turn it over to Paulette Chandler at the Brigham and Women's Hospital, who will discuss equity in issues of conducting COVID trials.
Paulette, you're on mute.
Great. So thank you. I'm going to be discussing equity issues in conducting COVID-19 trials, really from the perspective of the Moderna vaccine trial, which I participated in terms of engaging with the community and education. What is the context for equity issues in COVID trials? Well, when people of color think about participating in these trials, they have barriers: past and present abuse, discrimination, racism, low wages, segregated neighborhoods, food deserts, mass incarceration, which many think of as current day slavery, lack of access to healthcare, and ongoing police brutality. And of course, as we were recruiting for these trials, this was in the backdrop of social unrest, George Floyd's murder, Breonna Taylor, many things, but there were individuals that overcame those barriers and they opted to participate. And why does COVID-19 affect some groups more than others? We know that there are structural issues that contribute to these increased deaths in various communities. And for example, hospitalization rates, Latinx, Indigenous, Native American, Pacific Islanders, Blacks, 4 times higher than whites. And there are those structural issues: housing insecurity, overcrowding, lack of access to healthcare, poor dietary, habits that are integrated with the food desert issues. But also there's the death rate, more than 2.5 times higher than whites for these various groups. So it's important that these groups engage in these clinical trials because we want therapies that work for all groups. And many reasons influence why someone decides to participate in a trial or decides not to participate in a trial. Religious reasons. Some people say, I don't want to give blood because that's a sacred part of me. Conspiracy theories or personal beliefs. I'm concerned that that vaccine has a tracker in it. I'm concerned that the vaccine is trying to kill me, or some other therapy will kill me. And then safety concerns, the need for more information. And just because people are saying they don't want to participate doesn't mean that they don't want more information, because we know that even when individuals decide not to participate in a trial, just the engagement in that conversation prepares them for acceptance down the road. And then, of course, lack of trust. So when we think about addressing equity issues, we must think about building trust. And that comes in multiple ways. And so we have many opportunities to achieve equity. We know the social determinants of health are big. That's a framework for thinking about strategies to address equity. And we want multicultural media. Time, technology, and trust. There's a broadband, access barrier to even enrolling in trials, especially if trials have electronic ways of reporting symptoms. There's also the importance of having a research team of color. People want to see people that look like them delivering these messages. So we are strategic in developing that team. And then as we reach out to community-based organizations through town halls and local question and answer sessions, that team of color is able to engage in that community in a culturally sensitive way. And then taking advantage of resources that are already being delivered to these communities, whether it be testing sites or other social services. And as we build these partnerships, we want to think about it from a perspective of building strength. These communities are strong. They've encountered many challenges and they want to continue to empower their communities. So identifying influencers and ambassadors help us to build reciprocal relationships as we conduct these trials. Who's most trusted on COVID vaccine information? Physicians are, rated as being most trusted, but we know that there are other community influencers that are also highly trusted, including our local faith leaders. So when we think about overcoming distrust to participating in trials, and specifically the vaccine trials, using our teams that have already been engaging in these communities are important. For example, for the Moderna trial, we partnered with the All of Us research assistants because they had already been addressing recruitment for All of Us, which is a personalized medicine study to engage communities from diverse populations to share electronic health records as well as genetic data. So very sensitive type of research. And David, he shared his story with Stat, how his own cultural perspective with his own mother's concerns about the vaccine helped him be more empathetic to individuals that address questions about the vaccine. And partnering with community organizations that have already been delivering services in the community is a wonderful way to build trust in the community as well as extend that reciprocity. So we did community conversations and town halls with Sportsman Tennis Enrichment Center. We also collaborated with the Center for AIDS Research that, this work is built on work that's been done around HIV vaccines. And that's why researchers were able to collaborate so robustly across the world in terms of addressing enrollment of diverse populations for vaccine trials. So we were able to recruit our community leaders to engage in town hall discussions. And then of course, the Boston Neighborhood Network Media willingly shared this information. So when we think about building equity, we want to make sure that we're hearing from the various voices in the community. And of course, the Coronavirus Prevention Network hosted various seminars and educated the trial sites of various opportunities for their communities to learn about why is the vaccine important? Why are these other trials important? And confronting myths from a cultural perspective is important. So Moderna was successful in recruiting a diverse population, 20% Latinx, 10% Black, and we did it over a short period of time, even in the backdrop of social unrest. Even in Boston, we were successful with 10% Black enrollment, 26% Latinx, 12% Asian, 3% Native American. So in summary, when we think about achieving equity in our trials, we want to acknowledge past and present barriers to trial engagement, develop a diverse research team, use a variety of media methods to engage with communities of interest, and then partner with community stakeholders and influencers to develop relationships of reciprocity. Don't think about just diving in to get your data or to achieve your trial results, but think, how can we develop a relationship of reciprocity where it's a win-win for both the researchers as well as the community. And the next presenter is Bhadelia of Boston Medical Center, and she will be talking about the trials regarding post-acute sequelae of COVID.
Thanks so much, Paulette. Let me see if I can share my screens here. So as opposed to everything we've talked about with treatment, with vaccines, with diagnostics, our experience as Karen Jacobson said earlier today, is just starting with the post-viral syndrome that might be associated with SARS-CoV-2. And as opposed to sort of giving you lessons at the end, I'm going to start with a lesson at the beginning. My own experience with post-viral syndrome actually was not part of this epidemic or this pandemic, but with Ebola virus disease epidemic, where we discovered that a huge percentage of Ebola survivors go on to have a post-Ebola virus disease syndrome. And really the lesson out of this is that to have a longitudinal perspective, to have natural history studies that allow us to experience a disease, an emerging pathogen from the experience of the patient, allows us to get a better sense of the pathophysiology and the full scope of how we understand viral diseases. And this image is something that I took during a training that I did for Ebola virus disease, Ebola patient survivors, about a few months after their survival, where 50% of them were suffering from this. And the idea of a post-viral syndrome is not isolated just to the experience of Ebola. We know from chikungunya and the pandemic of chikungunya that there's a huge proportion of post-viral arthritis that is adding to sort of the long-term disability and potentially economic impact in Latin America and large percentage of places where chikungunya is endemic. We also understand that there are other entities that we don't quite understand, such as Moller's meningitis, the idea that it may be linked with herpes or varicella viral infections, or the catch-all, this idea of a post-viral etiology to chronic fatigue syndromes or the myalgic encephalitis. And so when we talk about SARS-CoV-2, our understanding is, as Dr. Kim talked about, in the acute setting, you have this amalgamation of direct viral invasion. You have microembolic and thrombotic complications, as well as this hyper-inflammatory maladaptive immune response. And right now, the way that we understand the post-acute COVID-19 period is that you have this subacute ongoing COVID-19 between 4 weeks and 12 weeks. And generally, the NIH's current studies, the ongoing cohorts, they describe enrollment and criteria as someone over 4 weeks after diagnosis. And in that period of time, a subacute and ongoing period of time, you have people who are recovering from either the hospitalizations, have persistence of symptoms that they experienced during the acute illness. But then after 12 weeks onwards, you have a more chronic or truly a post-viral syndrome that's defined by overall fatigue, a decline in quality of life. Multiple surveys have now shown that people have impact on their health-related quality of life scores, on their daily activities, activities of daily living, as well as joint pains, muscle weakness, and evidence of end organ damage, whether it be in the lung with the persistence of dyspnea and cough and oxygen requirements, or chronic kidney disease. And then in between, a whole host of cognitive disturbances, anxiety, depression, sleep disturbances, and everything else that you see here. And the understanding of how, one of the biggest challenges of long COVID, understanding long COVID, or the post-acute sequelae of SARS-CoV-2 infection, is simply that we don't know what the denominator is. We don't know how, because we haven't had well-controlled long-term natural history studies understanding this, we don't know what to make of numbers like this, such as a study out of China that says that 76% of inpatients had at least one persistent symptom 6 months out. And another study about, in February of 2021 that showed outpatients, even outpatients with not so severe disease had one persistent symptom 6 months out. At 3 months, we saw MRI changes that were correlated with continued anosmia and change in taste and in memory loss compared to healthy controls. We have cardiac imaging that appears to be abnormal in a small percentage of COVID survivors. And then we have, as expected, in more severe cases, moderate to severe cases, both CAT scan and pulmonary function test abnormalities about 6 months out. And related to this, the background of this is that there is viral RNA that was isolated in the brain, in nasopharynx, and on cardiac autopsies, suggesting direct viral invasion. And so the current hypothesis of PASS for the long COVID is all over the place. There's some understanding that this might be a result of the fact that people are critically ill and they're recovering from this, right? There's a whole literature on post-acute respiratory distress syndromes and post-hospitalization, or is it part of this initial hyperinflammatory response that causes things like fibrosis, pulmonary fibrosis that's discovered in many of the COVID survivors? Is it autoimmunity, such as our own work showed, which was basically that even 7 months out, many COVID survivors had autoimmune antibodies at higher levels than the general public, and then the rest of the conditions and hypotheses that you see here. And the current gaps in care, and in my summary is really, it's ending with questions rather than answers, is that as we develop this knowledge base, it is hard to figure out how we provide care for these patients. And the most advanced of clinical care guidelines are from the UK, helping to discover how we set up a multidisciplinary clinic that includes support for mood disorders, support for end organ damage, support for rehab, and all the other aspects that we've discovered within PASC or long COVID. But the difficulty is, how do we identify these patients? What's the case definition? How do we discover who's at highest risk? And how do we monitor the scope and the longitudinal progression of this disease? And what does PASC look like in the age of immunization? How does vaccination impact long COVID? So we're doing some work that has just started, which is looking at a longitudinal cohort of COVID-19 patients as they go through their acute and convalescent phases, looking at autoimmunity and inflammation. But as a community, as a Boston community, we have put in given the NIH investment to try to answer this question. As part of an extension of the investment that we've made as a partnership across Boston, we have put together a cohort, the Boston COVID-19 recovery cohort proposal, which is bringing together all the institutions you see here that we're hoping will answer some of these questions. So I'll end there and pass it back to David and Karen and Raj.
Great. We want to thank all of the speakers for their fantastic overviews as to where we are now, but also importantly, where we need to be going. And we'll invite all of the attendees to put their questions into the Q&A, and we'll do as many as we can over the next 10 or 15 minutes. So maybe I'll start with a question for Dr. Kim. How do we do better next time in terms of treatment? What did the UK do in recovery? Is it their National Health Service? Is there something else that was the secret sauce that we need to do in the United States so that next time we aren't, as we keep saying, building these ships while we're trying to sail them? What would you do different?
Thanks, Raj. Indeed, the UK benefits from this centralized system for health information that allowed 20,000 plus people to be enrolled in a single adaptive trial. As people know, in the US, we have a much less centralized system, different EHRs, which have not been adapted to clinical research. And so I would say that, and Sanjat alluded to this for diagnostic testing as well, that these sort of siloed and broken up systems are challenging when you're trying to get answers quickly. And while the US did respond with certain trials, I do think next time we'll have to build this infrastructure beforehand and use that infrastructure to answer important questions that may not be pandemic style, but in the meantime. And this means a little bit less of a free-for-all as what occurred. I mean, there are thousands of trials. Every company has a candidate or a trial, and how do we sort through that? How do we decide between them? And that does need to be more centralized than what we're used to in the US.
Maybe before we go on to a different topic, I'll ask Dr. Chandler and even Jacobson if they want to comment on clinical trials and equity. I think, Dr. Chandler, you pointed out what was done in vaccine trials and treatment trials, certainly outpatient treatment trials. The statistics for racial and ethnic minorities participating in some of the monoclonal antibody studies is closer to 5%, which is not where it needs to be. And Dr. Jacobson, I know at Boston Medical Center, you thought deeply about equity around clinical trials. Maybe you can, before we leave this topic, Dr. Chandler and Jacobson, give your thoughts on how we can do better next time with this. And I do think the vaccine trials are a model.
I think one important thing is to realize that it takes time. Building trust takes time, and people, some are very willing and eager to participate in these trials. They understand the importance. Like one of our trial participants said, oh, he hadn't even heard about the trials until he was watching the news one day. And he said, oh, there's a trial. And then he got on his computer and Googled and found the Moderna one at the Boston, at Brigham. And he said, I am so happy. I want to make a difference. And so it's important that we as clinicians not assume that someone does not want to participate in the trial. And the other thing is to be aware of the past experiences and the current experience and acknowledge them. And we as a community have to think about how do we address these structural barriers, racism, discrimination, poor housing, all these things that contribute to disparate outcomes and also serve as barriers for people to be able to participate in the trials.
I think that's great. I think another thing that we realized last year was that our network of where these trials got deployed actually also fell along lines that didn't necessarily hit all hospitals and community centers where we have diverse patient populations. So I think it was incredible to see even in our greater Boston area as many of these trials got deployed, but Boston Medical Center actually, which often serves a large portion of a diverse population, was actually late to being invited to some of these clinical trials. So I think as we continue to deploy these networks going into the future, we need to make sure that our hospital centers that have access to clinical trials are actually also the hospital centers, as we saw also in the New York area, that are not just the ones that have the names on them, but also that we make sure that our clinical trials are located in diverse clinical centers. And I think that was a real eye-opener for those of us as we struggled in those first months to get access to many of the newer drugs as well as the vaccine trials. And I actually think the vaccine trials did a better job with a little more time deploying in more diverse medical centers, which was really wonderful to see as well.
And of course, the community health centers are wonderful resources because the trust is already established there. So bringing them to the table early when designing the trial, making sure they have some financial benefit from participating in the trial also.
Yeah, I think that actually links really nicely into this next question as well, which was questions around the equity in the context of COVID testing protocols. So I think, Sanjat, you mentioned it as well, that even as we continue to go forward, we were really struck during the rollout of testing in this last year that it did not reach all of our populations as successfully as we wanted to. And what are thoughts about how to make sure that as we continue to message the need for COVID testing protocols, one of the attendees asked, how do we define equity in that as well?
Right. I think that's an excellent question and a challenging answer. I think when I think about equity, I'm thinking primarily of testing out in the community and not in the hospital, where it's pretty much universal testing. So in the community, how do you define equity? And I think one of the ways was alluded to by Dr. Dryden-Peterson's paper that I cited, this testing gap, where you actually are doing surveillance in the surrounding regions, determine what the incidence or the prevalence of the disease is, and then you modify your testing intensity to whatever the prevalence of disease is at the time. If there's a gap there, then you have some inequity. And so that's how I would personally define it. There are issues with that definition. A positive test doesn't always mean you're infectious, and there are plenty of false negative tests, but we do have a sense of the overall intensity of transmission in a region, and therefore we should allocate resources to where the intensity is the highest, rather than the way it is right now, where intensity is distributed based on where it's easiest. And that's not a viable option.
Really need a feedback mechanism or a continual monitoring with adjustments rather than an uncoordinated approach.
Right.
I have a question for Dr. Suliman. Sara, what's the effect on the test performance with the emerging variants that are arising?
Yeah, it's a fantastic question. So with the new variants, we worry a little bit about false negatives, and that depends on what test we're using. So for molecular assays where we're using PCR, if the test relies on regions of the spike gene, for example, that are highly mutated in these new variants, so we need to validate that we're actually still picking up these classes of variants. So because of that, we have pseudotypes for the virus that can be tested for that reflect the different variants. So we can experimentally actually test out whether the performance of the assay will drop. as a function of that. And for antigen tests, for example, there's the confirmation of the protein change in a way that makes it less likely to give us a positive result if someone is infected. And also thinking one step ahead, designing diagnostics that specifically pick out these variants. So specifically, lighting up if you have a mutation, for example, in the spike region or in the nucleocapsid region. So thinking both on the performance of the regular assays, but then designing new generations of diagnostics that pick out these variants as they emerge in the different communities.
Thanks.
Dr. Bhadelia, a lot of interest in post-acute sequelae of SARS-CoV-2. Maybe two questions. One is, what is your perspective on vaccination? Does vaccination of someone who's had COVID, who has some of these symptoms, help? So that's one question. And then a larger question is, you put up some data. How will we know what the denominators are? What type of cohort studies? This Massachusetts is the home of the Framingham cohort. Do we need a Framingham cohort for COVID? So two different questions.
Thank you, Raj. So for the autoimmunity component, it's really complicated, right? Because we actually see autoimmune antibodies in the aftermath of a lot of viral infections, not just COVID-19, and their place in pathogenesis has always been hard to determine. You've seen this with like B19, EBV. The early anecdotal evidence actually shows that those who suffer from a post-acute sequelae actually do better once they get vaccinated. We don't, there's hypotheses into that I think we don't have time to go into, but the concern of whether or not vaccines themselves may cause autoimmune reaction, I think we have not seen evidence of that with the number of vaccinations we've had so far in terms of evaluation of safety. And actually the opposite has been true, that people have actually shown that their symptoms get better. To the second question, that's what the hope is. I think that the BCRC's hope is that we do exactly that. The trouble with creating these denominators is we actually need to develop the tools as well. Many of the surveys, the evaluations that are used weren't even validated for SARS-CoV-2. The unique symptoms such as anosmia or loss of taste are not many of the health quality of life surveys, for example, that are administered. And so it's going to be again another example of building the ship while we sail it.
Maybe I'll.
Actually, Raj, I have a question for Dr. Kanjilal. So this is sort of two questions in one from Dean Daly. Right now, Harvard is doing testing for surveillance 3 times a week. With the efficacy of the variants of the vaccines, the question really is, what's the optimal frequency of surveillance testing in the population? And then we have another question that's sort of related from Russell Garlick that asks about preferred ways to screen people for vaccine effectiveness and preventing disease.
So to be very brief, because we're running out of time, to Dr. Daly's question, in my personal opinion, the intensity of testing should be guided by how many people are currently being hospitalized and dying, not the number of positive cases. And so it's really hard to predict what that's going to be in the fall, say, for instance, when we don't know what the vaccine efficacy will be against the variants. But if people are getting infected, but hospitalization rates are flat, and mortality is flat, then it makes the case that we're heading into seasonal COVID, right? And so therefore we can perhaps ease up on mass screening of asymptomatic people. However, if the variants are escaping immunity, then we can't ease up at all on our testing intensity. So it's a question that remains to be answered, but we will have to sort of continually be reassessing. And it's not something we can set a policy now in advance for. As far as your second question, what is the optimal, I think it was an optimal strategy for mass testing, is that right?
It had to do with preferred ways to screen people for vaccine effectiveness.
Oh, right, thanks. Again, a challenging question again, because the presence of antibodies itself doesn't necessarily correlate with protection, and therefore we need to have defined correlates of protection that then we can measure a quantitative amount towards to define whether you're protected or not. But the shortest and easiest answer right now is you want to look for vaccine-specific immune responses that are differentiated from natural infection immune responses, and then ideally try to correlate that with virus neutralization, which is the lowest hanging fruit. It ignores adaptive immune responses from the T cells, which are also associated with protection. But as far as sort of feasibility at the current time point, high throughput neutralization assays against the variants, looking at vaccine-induced antibodies would be the mass screening approach I would choose.
Great. Well, I think this was really a fascinating and really wonderful overview. We want to thank everyone who participated here for taking the time to help us look back on what's, I think, been really a remarkable year for science and obviously for humanity. We also want to thank the MassCPR again for the regular organization and leadership it's taken in terms of bringing this community together, both more locally here in the greater Boston area, but really globally as we've had partners and groups call in really from many diverse parts of the world. We look forward hopefully to a year of more exciting and hopefully now with greater optimism, hopeful science, and also hopeful that we have continued investment into the public health and scientific leadership that we've seen over this past year. So again, thank you for everyone for joining us today, and thank you again to our speakers for really excellent overviews.